Thank you for that. I hope you guys can hear me. Um, it's quite nice to actually see so many people show interest on this topic. My name is Reza Faizafan. I'm pain medicine specialist and also anesthetic consultant. I work in private and also public hospitals. The objective of my presentation is to actually make low back pain and approach to that very simple. And for that purpose, I dissected and simplified 4 common causes of low back pain. How do they present to us or to you, and what are the common features and how we can manage them, which I believe is a complex problem. And to just make some addition to the presentation, I'm adding some information about common terminologies we use in our correspondences and reports. As per interest, going to talk about some pain interventions and the treatments that I use often. So the problem with the back pain is actually the fact that it's very complex. They don't come to you or to us with simple or single pain generator. They have got multiple problems. And unfortunately, those pathologies, those pain generators, they have got some symptoms which overlap with each other. So when I see a patient or you see a patient, it's very hard to actually pinpoint and say that this is the cause of back pain. And generally speaking, this is a chronic problem. And in chronic pain, people come with hidden agendas. They come with multiple psychosocial issues, which by itself make management of these a common problem, very difficult. Now, to go through the back pain, I chose 4 common problems, and the first one is degenerative disc disease. In fact, it is a very generic terminology. As it says, it's degenerative changes, it is age-related, but it's more often you will see them in a working age group. It's a process that the disc in between the vertebrae loses its the spring quality. It loses its integrity, and now it is narrowed, is not functioning as normal, hence the pressure on other part of the spine becomes too obvious, such as facet joints and ligaments. Patients can come to you with after an incident, such as they may say that, well, I just bent to put my shoes on and something happened in my back. But sometimes it may be a chronic process. They come after many years of pain problem and present to you. Usually speaking, they tell you that the pain is in their midline, what can generate or refer to other parts of the body. But one common thing is the fact that they tell you that the pain is felt as muscle spasm. Their back is stiff, is tight, it's painful in every direction. Sometimes they may tell you that they have got pain going all the way down to their leg. Looks like a sciatica without any evidence of nerve irritation. And that is sometimes due to release of disc material into the spinal canal, which cause some chemical neuritis. And although you're convinced that there is a disc hernia, you do investigation and there's nothing there except kind of narrowed disc space. There is nothing specific in terms of examination finding, but generally speaking, they are stiff in their movement. And in acute stage of the process, you will see this really tight, big spasm in paraspinal muscle. And because of that spasm, the lumbar lordosis may be less, or on X-ray, you may see a straight vertebrae. Investigation-wise, in fact, everything should be according to excluding other pathologies. And X-ray is the first to request. And on X-ray, you may see that some of the discs are narrow or smaller than comparing to the others. And MRI is the one that shows you the exact disc problem and change in kind of a water content. Treatment-wise, if you noticed, I'm not mentioning anything about red flag because next presenter is gonna touch base about those red flags. So we're assuming that none of these cases, they have got red flag, hence the management should be conservative. Simple painkiller is sufficient for these cases to begin with. Anti-inflammatories is very helpful, especially for the muscle spasm. And if you think that there are some features of nerve irritation, a short-term anti-neuropathics can be helpful. Certainly, I don't recommend any long-term rest, maybe a couple of days, but anything I would say, I would tell them that just carry on as normal. But if you're playing rugby or if you're running 10 Ks a day or 40 Ks cycling, then avoid that for a while until you get better. And if ever a patient requires some strong opioids, then I usually make it clear that that's for a short period of consumption. Referral to a specialist is usually generic, actually. In this case, if there is any significant functional decline, patient can't go to work, can't do the normal house activities, the opioid is getting out of control, and despite all the management, patient is not improving, then referral to physio and pain medicine specialist is appropriate. Surgical referral can be done for this degenerative disease, but the next presenter will mention about the specific indications for that. Following from degenerative disc disease comes to disc prolapse. In fact, it's very common. If we go and do an MRI, all of us, if we go and get an MRI right now, I can guarantee that all of us would have some disc bulge somewhere in our lumbar spine. So it's pretty much incidental finding. And to make the diagnosis that disc bulge is actually the cause for pain, we need to have a correlation between patient's history and our clinical finding. And generally speaking, the disc bulge becomes clinically relevant if it's touching a nerve, is causing some nerve irritation. Hence, you will end up with a radicular pain like sciatica and descriptions of neuropathic pain. In terms of patient's descriptions, as I said, if it is symptomatic, and by that I mean if the disc bulge is touching or irritating a nerve, then the patient would have pain in distribution on that specific nerve root. And neuropathic pain descriptors would be pins and needles, tingling sensation, feeling numb, but actually the genuine true neuropathic pain is the one that patient can't describe it to you. He would come and say that, doctor, it's just annoying, it's uncomfortable, it's there. It feels numb, but I touch and my skin feels normal. Those are the type of descriptions for true neuropathic pain. Examination-wise, nerve root irritation tests such as straight leg raise test and slump test are two that I do on every single patient that I have, and they approach me with back pain. Obviously, I complete my examination with muscle power and sensory testing as well. The investigation to choose would be MRI is ideal because it shows the exact tissue problem and irritation to the nerve, and it makes a diagnosis much easier. In terms of diagnosis, a very quick one, and that is kind of a screening type of examination for muscle power. I get them to walk on their toes, on their heel, and squat up and down. It's a very quick way to see if patient has got muscle weakness. And if I'm concerned, then I go and sit down and examine each individual muscle group. Everyone can do it regularly to remember. I have got this copy on my and I've printed out Spinal Injury Association. It's a very busy paper, but the red light are what I need. So I just put it there, very simple, it's 10 seconds job to assess the dermatomes in the leg. In terms of slump test, well, straight leg raise test, I think everyone is familiar. And to just show you the slump test, I can run this video for you.
A sacral sitting, so you're going to say, let it slump down from really round back, and then as we bring our hand into that flexion. And I tend to, having a hand, very gently, keep them in that flexion. Okay, then you're going to ask your patient to go ahead and unconsciously. Go ahead and straight your right leg out, and then get into this position.
So this is the slump test. And usually with this maneuver, patients, all of them, they say, oh, there's a shooting pain. And that is a time when I actually make it clear that is it the muscular stretch in the back of their leg, or it is a genuine, sharp shooting electric shock pain going all the way down to their leg. And then I can differentiate a nerve root irritation. The treatment for this prolapse disc or disc bulge is actually conservative again. Majority of them gets better within 6 weeks. The severity of that become less. I can give anti-inflammatory at the beginning, and that kind of reduces the swelling around the disc bulge and can open up a space for nerves. Anti-neuropathic agents, they kind of, the evidence is getting weak actually, but still I do use anti-neuropathic agents if there is any radicular pain. Physical therapy in terms of physio and stretching is very useful. And if I need to give opioid to just get them moving and get them engaged with physiotherapy, I can give opioid for a short period of time. The other treatment options would be nerve root sleeve injections or epidural injections, which I'll come back to that a little bit later. When to refer? Well, if there is no improvement after 6 weeks, is quite severe. Again, significant functional decline, patient can't sleep, is affecting their mood, is just affecting their lifestyle, then I'll refer the patient. If patient has got radiculopathy, and that means a nerve pain associated with features of nerve dysfunction, like now patient has got numbness in the leg or has got some weakness or some altered sensation, then it means that the patient needs to be referred. And usually, if it is to do with a true disc bulge, the surgeons are the first point of contact. If it is not clear cut, then the pain medicine is a referral point. Moving from there is the third one is spinal canal stenosis, and I'm sure you have read that on a lot of reports. It can be due to single pathology like big, large disc hernia. Thankfully it is rare, and if it happens, it mainly kind of like emergency case. We need to be careful to exclude Corday-Carina syndrome, but most of these ones actually chronic. They're multifactorial, generally speaking, facet joint arthropathy, disc disease, spondylolisthesis altogether makes that the spinal canal narrow and cause some irritation. Patient comes to you and says that they have got pain for many years. Now they have got shooting pain down to the leg, like nerve irritation. They say that when they walk, they feel better if they lean on a trolley, and that's my typical question, or they lean on a kitchen sink when they're washing the dish. They don't like lying on their back because standing straight actually narrows the canal, and that generates more pain for them. So when you examine them, and if a patient says, I can't lie on my back because my pain gets worse on my leg, possibly it is to do with a stenosis. Another thing is they feel harder to get down the stairs because, again, they have to stay upright, and going up is better for them. Specific examination is, again, there is nothing specific, but the test for nerve root irritation can be helpful. And they may have a completely normal examination as well. And as I said, usually when they lie down on their back for a while, after a while, they say that, look, my pain in leg is getting worse. CT scan and MRI is two initial options for investigation. And both of them are good, but MRI scan can show a little bit better in terms of disc bulge or nerve irritation. Spinal canal stenosis is multifactorial. Usually treatments in terms of anti-neuropathic agents and analgesics, they won't help as such. They do better with physiotherapy, stretching, and physical therapy. They may do with weight loss if they can do. And pain interventions can provide temporary pain relief. They don't last long because the problem is multifactorial. Hence, if they have got neurogenic claudication, if they have got radiculopathy, large disc, then referring to the surgeon is good. And if they are not suitable for such invasive treatment, then the pain medicine can be helpful for these patients. And the last of common problem, which is actually the most, I would say is the commonest problem, is a facet joint disease or arthropathy. It is seen more in elderly group. They say that their back is painful. They find it hard to actually roll from side to side during the bed. Leaning backward can be painful for them. And sometimes they tell you that the pain goes down the leg. And it's very typical, most of the time, that referred pain stops by the knee. So that question is important. Does the pain go down to your foot, which more looks like a nerve root irritation, or stays around the knee, which probably is a referred pain? The specific examination is facet joint provocative test. I'm going to show you in a video. X-ray, CT scan are helpful. Bone scan can be very helpful because it shows active disease where we can target specifically. That is a quadrant test. That's a facet joint provocative test. So this actually is quite reliable. The second thing I do is get them to stand, and then I get them lean backward on their spine and putting pressure on the facet joint. So I do two different tests if I'm looking for facet joint or nerve irritation. Treatment of that is physio. They need to keep moving. They need to keep those facet joints active. I don't know if it is right, but I tell them that facet joint is like a door hinge. They get squeaky and you need to keep them moving. Some of them like my example, but some of them they don't like, but that's what I tell them. Simple analgesic is helpful, and facet joint injection mainly for diagnosis, and also rhizotomy for giving them long-term pain relief. When referral, as you notice, is actually a referral of referring these patients have got the same criteria: significant functional decline, escalating opioid use, or no improvement despite all conservative management, warrant a referral to, in this case, physio and pain medicine. So common terminologies very quickly. Spondylosis is generic term. It means wear and tears in the spine, nothing specific. Spondylolysis is another terminology of past defect, and it's common in younger age group population and active people. Radicular pain, as I said, I tell the patient, does it look like sharp shooting electric zap going all the way down? And that's how I describe to the patient and get the feedback from them, like sciatica. And generally speaking, if they have got true radicular pain, it is associated with neuropathic pain descriptors as well. Radiculopathy, I should admit, or I must admit, it is a terminology which even we as a professionals, we use it wrong. Radiculopathy is nerve pain associated with nerve dysfunction. So patients need to have numbness, permanent altered sensation, a weakness, which warrant an urgent referral, because anything less, if you delay and carry on with a conservative management, they won't recover. It tells you that there is some problem with the nerve, and we know that once there is a nerve damage, it doesn't come back. Referred pain, I'll give you an example. Facet joint referred pain goes to legs, but generally speaking, it stops around the knee. Sacroiliac joint pain radiates to gluteus buttocks, sometimes to the top part of the femur, and hip joint pain goes all the way down to the femur to the knee as well. Common pain procedures. The first one is facet joint injection. The other name is medial branch nerve block. On the picture, you can see the black arrow showing the facet joint. We go and inject into the joint local anesthetics and sometimes cortisone. I generally tend to inject where the yellow arrow shows and indicates, and that's a medial branch nerve. It's a nerve which supplies the facet joint. I'll go and inject a little bit of local anesthetics. If patient tells me that, Reza, it was beautiful for 16 hours, but my pain came back one day after injection, I said, great, because I know that the facet joint is the cause of this pain. Now, two specialist group do this injection. One is radiologist and one pain specialist. And if you have noted, radiologists inject 1 or 2 facet joint at a time. And it's that purely to do with billing differences in these two group of specialists. In my opinion, facet joints, they come in a group. You don't have one facet joint disease. Usually there are 4, 6, 8 of them that have got degenerative changes causing pain. And I think doing one injection at a time probably won't actually confirm or diagnose correctly, because the rest of them still is going to give patient pain. If I have got definite confirmation that this is the facet joint is causing a pain, then I move on to rhizotomy. Other names for that are neurotomy or radiofrequency denervation. There are 2 ways. One is thermal, and the other one is pulse, RF, and we do thermal one for the facet joints usually. It creates a destruction in the tissue. We heat up tissue to 80, 90 degrees. We create a burn where that medial branch nerve was next to the facet joint. And we aim to give few months, hopefully up to a year pain relief. So next time when you have got a patient coming to you after rhizotomy, complaining that the pain is flared up and is now really bad, it's normal, because we have created a lesion. And I tell the patient that up to 4 to 6 weeks, the pain is going to be worse than what it is, but gradually will get better. Simple painkillers, sometimes low dose amitriptyline is sufficient for these patients. Nerve root sleeve injection or transforaminal epidural injection. You can order that if you have got confirmed disc bulge or foraminal stenosis touching a specific nerve root. We can give injection with local anesthetic and cortisone and open up that space for them. At the same time, it can be a diagnostic technique for the surgeon, so the surgeon can specifically identify which level is causing the pain for that patient, so operate specifically on that. The third one is epidural injection. Interlaminar epidural, like epidural in labor ward. They go from midline, and as indicated in white arrow, and we inject local anesthetics and medication where the dotted white line is. Unfortunately, that is not a place where the pathology exists. Pathology exists like disc bulge, where the red dotted lines are. So it's different anatomy in the spinal canal. And to reach that area, usually we need to give caudal epidural. We go from the caudal with a special catheter, reach that space, and dump some local anesthetics and other medications. And again, you can order these injections if there are multifactorial spinal canal stenosis, if there is disc bulge, and some of the pain specialists do these injections for degenerative disc disease as well. Medications, this is what I use. This is my practice, guys. My anti-inflammatory tablet is COX-2 inhibitors because of their lower side effect profile and I only give them for flare-up. I don't give them on a long-term period. If I'm going to give antineuropathics, the first thing is amitriptyline and nortriptyline, because that is actually has got the best evidence for nerve pain. I don't give them, I tell them to take not later than 6 p.m. because I don't want them to wake up with cognitive decline or feeling like a zombie the following day. Pregabalin is another one. I start very low dose at night time and gradually build it up. If there is no any effect, I wean and I stop, because actually pregabalin has got some addictive properties. And if I think patient have got anxiety, depression, or some kind of widespread pain, I'd go for duloxetine because that can be useful for that purpose as well. Fish oil and turmeric. Almost I give to all my patients, and that 9 gram is not a typo error. It's genuinely is 9 gram. And I give them for 6 months. They have got some evidence for inflammation and can be useful. PEA, I'm sure you have heard about that. I usually call PEA a celebrity on the block. It's quite getting popular, and there are some evidence in terms of helping with nerve remodulation and nerve function repair, let's say. Clonidine is a substance or drugs that I use quite often when I'm doing opioid rotation to prevent withdrawal symptoms. I use that for anxiety, and I use that for insomnia or sleep problem. It's safe, it's not addictive. The only thing, if I'm using them for long period, I wean them off because they can cause rebound hypertension and tachycardia. And ever if I give opioids, I've got 3 options: tramadol, tapentadol, buprenorphine. They are atypical opioids. I rarely prescribe anything else. I have given some other opioids, but it's really, really less than 1% of my prescriptions, perhaps less than 1%. I usually avoid immediate release opioid in chronic pain setup, but I do give more liberal in elderly aging group than the young population, and I don't remember prescribing any benzodiazepine except clonazepam for 1 or 2 patients. Physio, I refer them to a physio who does active treatments. I'm not interested in massage, soft tissue release, which I like actually having it, but for patients, they need some assessments, they need posture correction, they need to have some stretching and some home exercise plan to carry on their daily basis at home. Hydrotherapy, if they are available to, if they are able to actually access that, and I suggest them Pilates and Tai Chi, because these are the 2 kind of a group exercise which focus on the core muscle. The core muscles, what I mean is abdomen, and we know that the core muscle is what is supporting the spine. So they are very helpful. And it's generic. This is almost my approach to any patient with back pain. Usually they come to me with years of pain. I'm only interested in, tell me, how did it happen? Did you have accident, surgery? What was the cause? And then I'll focus on current pain problem. And I try to elaborate and see what are those symptoms that I mentioned in those 4 common pain generators. Which one of those symptoms are more obvious in this case to make kind of differential diagnosis for myself? I ask about quality of that pain. I ask where the pain is and where does it go. Then I become a little more specific. Rather than asking what makes it better, well, the answer is lying down. What makes it worse? Activities. But I ask the question specific. For example, does leaning forward make it worse? Turning to the side, is it bad? And those type of things that I mentioned in my 4 causes at the beginning of the slides are what I ask specifically. Definitely I'll look for red flags, and I spend considerable amount of time on psychosocial component, because I want to know why this patient is coming to a doctor now, why is coming to see me, and what I can change in their life to help them. So if you have noticed, I don't say anything about reducing the pain. I just want to change things so they can function better. And obviously I'll move on with the specific examination and investigation and make a full treatment plan. And the last bit, which is elephant in the Zoom, is medicinal cannabis. The Faculty of Pain Medicine has announced, and currently there is no evidence for cannabis except pediatric epilepsy and also MS-related pain. Hence, anyone comes to me with the question, I tell them that evidence is there, and I don't prescribe unless there is strong evidence supported by the Faculty of Pain Medicine. And I'm going to stop here. I'm not sure if you have got time for questions, but we can certainly look into that or just move on to CMAC.
Reza, I think we're going to keep the questions till after the end of CMAC's presentation. So if I could ask you to put yourself on mute.
Sure.
And,
thank you.
CMAC, would you mind sharing your screen now, please?
Sure. My name is CMAC Seresti. I'm an adult and pediatric orthopedic spine surgeon. I work both at Royal Paris and Paris Children, and also at John Pell's campus in St. John of God, Subiaco. I've been asked to talk about back pain tonight. Back pain is a large topic to cover. I won't be able to cover all aspects of back pain. Reza quite nicely defined the history, clinical examination, and non-operative management. I more touch base on what's important for me as a surgeon to know in history. How can I narrow down my diagnosis? Which image to order, how to interpret them, when to refer them to surgeon, and it's absolutely essential to refer them urgently. Who needs surgery? What surgery can we do for them, and how they benefit from this surgery. Also talk about back pain in pediatric population, but that will be entirely a different topic. I'll just touch base and go through it very quickly if you have time at the end. I'll go through the facts, but obviously we all know that 3 million of Australians suffering from back pain. That's 1 in 7. Back pain is ranked first in disease burden in Australia. Is a leading cause of disability in working population here in Australia, and the most common musculoskeletal presentation that patients are consulting GPs. The other fact is the longer the patient is off work because of back pain, less likely they're going to return back to work. Etiology of back pain, I define them and divide them into spinal and non-spinal causes. Spinal causes, which I'll go through, it can be fracture, infection, rheumatological causes, deformity or degenerative, which Reza went through all of them in the degenerative section. Non-operative, non-spinal ones could be outside the box, which we must think about, otherwise we miss great things such as cancer, aortic aneurysm, or kidney stones. Other causes could be psychosocial or multifactorial. Spinal causes in specifically would be degenerative, which can be in the front, which is discogenic, or in the back can be facet joint disease. Radiculopathy or radicular pain because of the disc bulge or foraminal narrowing, and also after the surgery, which they can have adjacent segment disease, which is outside the scope of talk tonight. Always focus on red flags. Age-wise, anyone less than 18, teenagers or kids having back pain is a red flag unless there's a very good explanation for it. Also, on the other hand, elderly with back pain, they're more prone to other diseases such as cancer, osteoporotic fracture. That's another red flag. Anyone with a history of trauma, long-term steroid use, intravenous drug use, poor bone quality, osteoporosis, cancer, infection can be red flag. Unexplained weight loss, nighttime pain, and pain that does not go away with rest is a red flag. Thoracic back pain is a red flag. is different from lower back pain. You shouldn't have back pain in the back of our chest. It's only rare diseases that cause that, like ankylosing spondylitis, for example. Otherwise, there's some sinister pathology underneath it. Anyone with obvious neurological deficit or fever falls in the category of red flag. Red flag means we need to investigate them quickly and vitally, or refer them straight away. In terms of history, we all went through medical school, how to approach back pain. You ask about age, where the pain is, how long you had it, and these are good questions, but I have a practical way or approach when I see a patient. I essentially ask what troubles them the most. Is it back pain or leg pain? First question defines and delineate for me if I'm dealing with a pathology of the back, which is normally degenerative, or even could be fracture, or is it leg pain, which is nerve problem or radicular pain or neurology. And then I'll focus on that. What makes it better or worse? Claudication, which Reza touched base, is a very good one to rule out. If they get worse when they're walking, they get better with leaning forward, such as leaning on shopping trolley, that's a sign for claudication. Always ask for bowel and bladder incontinence, and also nocturnal pain or nighttime pain. Physical examination, Reza also touched on that, so I don't go through how I examine them. But as a brief summary, in terms of nerve root distribution, L3 is around your knee, so knee extension or anterior thigh. L4 and L5 got through with your ankle dorsiflexion, so you get foot drop if you have L4 or L5 problem. And also S1 is plantar flexion. I always ask the patient to toe walk and heel walk, these two, and demonstrates quickly if any of those nerves are injured or under pressure, or because of the pain or inhibition, they can't function perfectly. And then I can focus on the rest of the examination, match it with the imaging to come to a diagnosis. I just don't look at the MRI scan, and I can tell 95% of the diagnosis is made by taking history. The rest of the 5%, you can get help from examination and imaging. If you go the other way, you get lost, because as Reza said, loss of imaging have abnormalities which does not necessarily match with patient pathology and symptoms. Imaging, what imaging I order, that is essentially based on my clinical diagnosis. I don't go first for MRI scan unless I have a good reason for. One take-home message, if you guys want to have from tonight's presentation, is the importance of erect X-ray. And I always get erect, and I'll show you why in the few slides to come. Anyone for a query about fracture, flat back, which I'll explain which one is flat back, or spondylolisthesis, I start with simple erect X-ray. That gives me a lot of information. Malignancy, yes, MRI and CT is the way to go ahead. This degeneration, also erect X-ray helped me with the definition of sagittal balance and normal alignment of the patient, and MRI scan also would be helpful and give me additional information. Acute disc prolapse, patient comes with radiculopathy, foot drop, yes, MRI scan is a good way to start. If you don't have access to MRI, you can order CT, and sometimes you're lucky to see the disc prolapse on a CT soft tissue window, which I'll show the example of. If you're not sure where to start from, or you're just getting lost, erect X-ray of the lumbar spine or tracolumbar or the entire spine will be a very good starting point. In terms of X-ray, always get erect X-ray unless there is some other reason to get supine. Erect X-ray is a functional way that we all stand or walk, and it shows the alignment of sagittal and coronal balance. The other type of scan is EOS scan, is when the patient is standing up, and that shows the global alignment of the patient. I've got a few examples of that and show you how I interpret them. X-ray also good to show fracture, normal alignment, or any instrumentation they had from previous surgery. MRI or CT only focus on the details and cannot show the global picture of the patient when they stand. These are some examples. If you don't examine the patient or don't ask history properly, you get missed and you will miss the scoliosis. Scoliosis is pain-free. It does not cause pain in pediatric population. However, in adult, it can cause degenerative changes in the facet joints and then becomes painful. So degenerative scoliosis is painful, whereas adolescent scoliosis essentially is not painful at all. So simple X-ray can essentially make a diagnosis straight away. The other one is erect X-ray, which can show is fracture. What I look for the height of the vertebral body above and below, and can compare, and quite clearly here I can see the fracture is a compression fracture. Is that enough to make the entire diagnosis, saying one X-ray for me is enough to see all the information or get all the information I want? No, but that's a good starting point. I can see the global alignment. I can't see anything out of the picture. The anterior vertebral line and posterior vertebral line is aligned, so I know that there's no dislocation. But also I'll show you how this one can easily not showing other small things that could be potentially important. So erect X-ray is a good starting point, also in the lumbar spine. This one is erect and is neutral, and that gives me a lot of information straight away. Apart from the calcific aorta in the front, and also degenerative changes in the back, which is our hypertrophic facet. They are sclerotic, they are a bit wider than what it normally should be. I can see the end plate sclerosis. Also, I can see the disc height here is decreased compared to other levels. So that is straight away tells me some multi-level degenerative changes. The other thing that we can pick up here is anterior stasis or spondylolisthesis of this vertebra L4 and L5, which I'll show the example of that. If you look at the MRI, that goes back because when the patient lies down, the gravity takes it back and you easily miss it. So that tells me there's instability here that drives the force or part of the force and the pathology. EOS or global spine, that shows me the global alignment. That's a classic example of flat back. What is flat back? We normally have kyphosis in thoracic spine and lordosis in our lumbar spine. When we lose our lordosis, such as here, as a compensation, we have to lose our kyphosis up there. And that means we have to really try to sit up. And that requires a lot of muscle force from the back. As we get older, we cannot put up with this muscle strain and we gradually hunch forward. So aging is a kyphosing disease. And we gradually go and hunch forward. That's all because of this degeneration and flat back. This is a classic example of EOS when the patient stands up. We don't need to know much information about it, but that's enough for me to tell. This patient have the head above the pelvis, has to flex the knee because it's got the flat back and got lost in the kyphosis of the thoracic spine. So that straight away tells me it's multi-level degenerative changes, the flat back disease, and also going to the extreme of the compensatory mechanism by flexing the knee. CT scan, yeah, is very good to give me more details about the fracture. If you're lucky, we can see the disc prolapse and soft tissue window. I have all the examples there to show you. And also vacuum changes, so gas in the disc also is a sign for degeneration or sometimes instability. SPECT CT is more specific type of CT, which shows the osteoblastic activity. I'll come to that in the next slide. This was the example of the fracture that I show you in the X-ray, which we quite clearly could miss this retropulse fragment that can easily paralyze the patient. So if we start with the X-ray, we can follow with the CT, and we follow the path of our diagnosis very nicely and quickly. That's the same patient that I show you, and you can tell got a disc bulge that spondylolisthesis is lessened in the CT because it's a supine thing. And also we can see all these hypertrophic facets in the back and degenerative changes, vacuum changes in the disc. That also gives me a lot more information of see. This is a disc bulge that I was talking about on a soft tissue window. If the patient comes with a pathology at this level, that's enough for me to make the diagnosis and even do the surgery. I don't necessarily need to have MRI scan. Another example of CT scan with vacuum changes in the disc shows this disc is still mobile and active and is really degenerative with this anterior osteophyte. Multi-level disc degenerative changes. This is an example of pars defect. What is pars? Pars is part of the posterior spine alignment that connects your superior articular process to your inferior articular process, such as this one. Whereas here, this connection is lost, so that's a pars defect. The reason for that depends on a patient age group could be different. The most common one is in young population is isthmic. Isthmic pars defect is essentially a stress fracture or repetitive hyperextension. This actually digs in here and cracks, often causes fracture of the pars and level below. Is more common at 5-1. This is also a CT scan, so I cannot say if this is staphylolisthesis or not unless I get erect X-ray. But that's enough for me to make the diagnosis. So next step for this patient for me would be to get erect X-ray and also maybe MRI scan to have a look at the disc. That's an example of a SPECT CT, which is a combination of CT scan and also shows the osteoblastic activity. So clearly here you've got a pars defect. Pars defect can be old. Patient can have it from age of 15. They present to you at the age of 45. In that 30 years, that can settle down. But if it's still active in a young person, that's a pain generator and a source of pain. So they can be amenable for surgical fixation, such as this one. MRI scan, yes, MRI is very good, but it's most accurate and reliable to show you the soft tissue, which is disc, ligament, neural elements, and rarely can show you the bony pathology if they're microtrabecular. It does not show you the alignment, as I said, or spondylolisthesis, because that's performed in the supine position. It's not a good thing to do for obvious, follow about the obvious fractures. And in MRI scan, I'll normally look at the T2 signal images. It's a clear example of the disc prolapse. Obviously, everybody can see. But what is also important here, you have the flat back. So it's lost the lordosis, most likely because of the pain. The other thing I'll look at is normal disc has gray or white changes in the middle, which is nucleus pulposus, with the annulus fibrosus, which is black ligament around it. Whereas this disc is completely black, which means loss is water content, is degenerated. The annulus fibrosus is thinned out, torn, and the disc material, which is the nucleus pulposus, popped out. Although this one can cause radiculopathy, can cause back pain. Back pain is because of disc degeneration. Radiculopathy or leg pain is caused by disc prolapse. We only take disc prolapse to relieve the leg pain. To be able to handle the back pain, we need to do something else for the disc. So these are two pathology and two entities. This is another example of why CT scan is really, really good to show you the alignment changes. That's the same patient I showed in the first picture with the spondylolisthesis of 4-5, and this is her MRI scan. It's pretty much back to normal. So you could easily miss that if you don't go ahead with the X-ray, if you don't start with X-ray. So another example of disc prolapse and also disc degenerative changes. So they can cause two problems, back pain and also leg pain. It could be a foot drop, it could be a swan problem, but to manage these, they have two different options. So you can't just promise them to get rid of all their pain with surgery. Also, if you're interested, there's some terminologies about lateral recess or posterolateral lateral paracentral disc protrusion or stenosis. Essentially, this is a central part of the canal. This is paracentral lateral recess. When the nerve goes out, it goes through the foramen, and that's the extraforaminal. I look at the midline, which shows the CSF, and the nerve roots, all these dots in the axial view. Here's a clear example of wide canal, no stenosis, nerve is going out happily, there's enough space around it. They're all floating in the CSF, there's no stenosis. These are the facet joints in the back. Whereas this one clearly shows you the stenosis, hypertrophic facet, all codequino, the nerves are jammed here. There's not much room for the nerve to go out. And you can see the size of the facet joint is quite hypertrophic. That's a sign of degenerative changes with canal stenosis. That's a classic example of someone with claudication. I triage them based on the pathologies when I want to treat them. And essentially, specific spinal pathology means those with fracture, tumor, etc. There's about 1% of them. 5 or 10% can be present with radicular pain. It's about 5-10%, but the majority of them are non-specific. They need more workup, and they're not all of them amenable for surgery. They all need a holistic or multidisciplinary team approach, including pain medicine, physiotherapist, and a surgeon if needs be. In terms of treatment, I think Reza touched based on non-operative management. I try to more focus on the surgical part, but essentially treatment requires patients' active participation. They need to understand what the aim of the treatment is. Essentially for surgery, it's not going to be panacea. They need to understand what to expect after surgery, what to expect after seeing a physiotherapy or pain doctor. The pain might not completely subside, but it would be managed enough for them to get back to normal life. Or they need to change their lifestyle, or they might need to change their body habits and lose their weight. Bed rest, I'm not a big fan of bed rest. Maximum will be 2 days, or maybe for fractures, lie them down for a few days or even weeks before they get breast or surgery. But essentially, bed rest does not have much role these days. In terms of medication, I think Reza explained all of them. Orthoses or braces, I normally prescribe them for fracture. And surgical and non-surgical, which I focus on the surgical part. In terms of physiotherapy, I essentially ask for one thing, core muscle exercise. Stretching, all this training, they know how to do it and they do it perfectly. For me as a surgeon, anyone with the spine problem, I ask for core muscle exercise. Chiro, I think one of the participants asked about the efficiency of chiro. Yes, there is a role for chiro. The mechanism is not fully understood, but it's not a long-term solution. And I'm essentially not a big fan of chiro because manipulation without having imaging and not knowing the pathology can be quite dangerous, especially in cervical spine. It can and has paralyzed patients. In terms of sports, Pilates, yoga, and swimming are the best sports for back, and also for those who are able to, horse riding could be good because they can stand up straight and then fire the muscles. The other thing I always say is avoid lifting, repetitive bending, and twisting. These are things to avoid. Those are the exercises and sports to do. Ventral spine surgeon, I'll go through the more urgent one. Yeah, anyone with cord equina, bowel or bladder incontinence requires urgent referral. It is urgent because you have a very narrow window that can save them by doing the operation. After that, no matter what you do, there's no improvement in their function, especially when they have dense foot drop or full-blown cord equina. Doing surgeries has probably less than 1% chance of success. Whereas if they're deteriorating and if you decompress them early, there's a good chance they can recover from that. The aim of the surgery is to stop the progression of the disease. We cannot guarantee the recovery of the nerve. That's up to the body to regenerate. Others who might benefit from surgery, or at least benefit from seeing a spinal surgeons as a starting point, it could be the one that failed non-operative management. And those with radicular pain without any neurological deficit, if it's caused by disc prolapse, has failed injection, physiotherapy, they could be amenable for discectomy. Multi-level degenerative changes, spine surgery for them is not the best option. Flat back syndrome, yes, we could do them, we could do surgery, but that's not without risk, and the patient needs to be consulted beforehand. Aim of surgical management is essentially to relieve the pressure of the nerve. It does stop the progression of disease or neurological deficit. As I said, I cannot guarantee the recovery, but I can tell it does stop the progression of the deficit. If they come early, they might get the foot drop back, almost back to normal and fully recover. I do operate for fracture, and that's essentially for stabilizing fracture for that to heal. For multi-level degenerative changes, non-specific back pain, spine surgery is not the best option. There are some surgical solutions for it, but because it's degenerative changes, that happens in the level above and below, and they come back with more problem down the track. So it's temporary management by doing surgery. I'll just go through some of the options we can do. For example, for fracture, we can fix them and put them in a brace. That lady with a flat back, you can do osteotomy and fix and stabilize it and change this from flat back to nice lordosis and kyphosis. So get rid of the patient's knee flexion as a compensatory mechanism. That definitely helps with the back pain. Spondylolisthesis also needs decompression and fusion. If you just do decompression, that will listhese more and gets more unstable. You can do simple decompression or laminectomy. What is laminectomy? Is removing all these lamina on the back, inferior and superior articular process, get rid of all this ligamentum flavum, and basically the cord and all the nerve root which was deflated inflates and come back to normal. That's the surgical site that the lamina was taken away. Yeah, or you can do simple discectomy. In this discectomy, we don't take the whole disc out. Essentially, we just take the extruded and prolapsed part of the disc. You won't be able to take the entire disc out, and it's not recommended at all. So this patient won't have leg pain anymore, or essentially will come back with back pain. So we need to consult the patient before doing any surgery. You have to manage the expectation from surgery, what to expect. Similar scenario, but this patient has more degenerative changes, and because this collapsed disc, has got a disc bulge. So essentially it's like a flat tire. And it happened because disc has lost its water content, it's deflated, and now it's got a disc bulge. If you just do it in discectomy, you don't necessarily address the problem, whereas you can do nice fusion from the front. You get the disc card back to normal and you fuse them. And that's one of the best operations for back pain and leg pain. One of the rarest, best operation, I would say. And lastly, for multi-level degenerative changes, there is no panacea. Surgery definitely is not the best option for this young person with the back pain. And the other question I always ask in the history, which I mentioned, was if the pain passed beyond the knee. If the pain is in the buttock or around the knee but does not go down beyond the knee, is a referred pain. That's essentially a disc problem or facet joint problem. It's not a nerve problem. And that helps me to differentiate the problem of the patient, whereas being disc, facet, or radicular pain. If it's just multi-level disc problem, doing surgery is not going to make the patient any better. Some patient populations are high risk for poor prognosis. Obviously, those with psychosocial problem, smokers, obese patients, and patients who don't like their job, and workers' compensation claims. There are essentially red flags in terms of management. I'll quickly go through back pain in children if you have time there.
We're running very short on time, CMA.
Okay, well, maybe a couple of the slides. So back pain in children, I think simply should be referred unless you have a good reason not to, because that's essentially an organic pathology. It can be fracture, infection, or tumor, or spondylolysis. Red flags is the same as adult, essentially age less than 10 must be referred. Nighttime pain is red flag for tumor, and obviously weight loss and fever. Physical examination is the same, but make sure you take this shirt off and you can see the entire body. You can miss things in kids that is not forgivable. Imaging, same, start with X-ray. That's a nice approach for back pain in children. Always start with X-ray. If I can't see anything on X-ray, still suspicious, then I'll go to MRI scan. It's an example of a tumor, which is hard to see on X-ray, but it can be proceeded to CT and MRI scan. It's not malignant, but it still requires a spine surgery. Spondylolysis, which Reza touched base on, is pars defect, and these are examples of pars defect which has been repaired or been fused. Thank you very much. Thanks, Marcus. Back to you.
Thank you, CMAC. If you could just stop your screen share, please. I'll open with some questions that were generated in chat, and either CMAC or Reza will answer the question where appropriate.
Oh.
So if you could mute yourself, please, CMAC, and we'll toggle between. So from Trin, no, how long after the nerve root injection can the patient get back to the daily activity or work?
I think that's for Reza to answer.
Yeah. Yeah.
Yes, so the nerve root sleeve injections, they work immediately because of the local anesthetics, but actually local anesthetic wears off very quickly. So the next day the pain will come back. And the only way that nerve root sleeve injection works is when the steroid starts kicking and gradually reduce the inflammation. So the effect of nerve root sleeve injection or epidural kind of, it's in terms of when they can them, they don't need a rest after these procedures. It's not like a surgery where there was a strict kind of like bed rest or gradual physio that they need. In fact, once they have got the treatment in terms of injections, I'll get them back to normal their activities. But usually with these patients, because they have been off work for a period of time, I get them to actually start slow. If they usually go and do 20 Ks, I usually tell them, look, I know you can do that, but in fact, by going and forcing yourself to do 20K, you are going to generate more ache and pain. So I kind of explain them to have a little bit of a stage-wise increase in your normal activity. Go back to work, that's fine. But if you think that the work is affecting your function, is causing more pain, then slow it down. In per se, I don't stop them from doing their normal activity or going back to work after these injections. Back to you, Mark.
Thank you, Reza. The next question is related to the role for chiropractic treatment.
I think I explained that in my presentation. There's little room for chiro in terms of treating back pain. There's no solid evidence behind it, but it's been popular and some patients have been very happy with chiro. Chiro for back pain, I'm not religiously against it, but chiro for neck pain, I'm not a big fan of, because that can cause some permanent neurological injury or even paralysis. So for back pain, I won't advise them to. If I have to choose between chiro and physio, I'll go for physio. As I said, there is a role for chiro. Essentially, is changing the body habitus, massaging, and maybe manipulation.
The next question refers to the evidence on the use of turmeric on chronic osteoarthritic pain.
Okay, turmeric is the evidence for that. There are some of the large randomized control trials, and they confirm that they have done in various ways of measuring free radicals. They measured inflammatory cytokines and also the generic pain relief or comfort comparing to non-steroidals. Beside the kind of a biochemical evidence, it's not inferior to using ibuprofen in osteoarthritis. It doesn't work as painkiller, so it means if you take the turmeric tablet, it doesn't mean that your headache or your joint pain in your knee pain is going to get better. But over long-term use, which my time frame is 6 months, by reducing that systemic inflammatory substance, it provides some pain relief or better pain control in this patient's group. So I do recommend, and I do prescribe and tell the patients to have it. Something I need to add, patient says, well, I use turmeric in my food. It's not exactly the same thing. In fact, you can have a jar of turmeric. You may not absorb most of it. So it is some part of curcumin or some part of turmeric which is absorbable and is useful for this purpose.
Thanks, Reza. The next question relates to the benefits of psychotherapy in, oh, I've just lost it, bear with me. Oops. The benefits of psychotherapy in pain management, and what about meta-inflammations?
The first part is psychotherapy. I think is a more of a terminology in psychiatry. But generally speaking, psychotherapy is the way that usually clinical psychologists and psychiatrists assess an individual's cognition, function, and barriers in terms of their interpretation of the condition. And they try to modify those things, not correct them, but modify them. It is very helpful, but it's not for every single patient. It are done by not every clinical psychologist or psychiatrist. There is a specific training for that. And I leave that one to those people to decide what is the best treatment option for kind of addressing psychosocial issues by psychiatrists or psychologists. There are a lot of other things. You can say that cognitive behavioral therapy, you can say mindfulness, acceptance commitments, and other things that they can use, all kind of under the umbrella of psychotherapy. They are more helpful in chronic pain conditions rather than acute situation.
The next.
Sorry, there was the next question, meta-inflammation. Maybe I need to explain. Meta-inflammation is increase in inflammation or systemic inflammatory markers, which is related to diet, such as obesity. We know that right now, the people who they have got higher BMI, they have got higher inflammatory markers in their body. And we know that these people are more sensitive in terms of simple trauma, such as simple touch or hit to their skin. They feel that pain more. And generally speaking, because of other issues, the stress on the joints and various parts of the body is high. So all of them contribute to their pain picture. So in medicine, perhaps the strongest evidence between chronic pain is with high BMI. So we know that high BMI patients that are in a risk group developing chronic pain. You may want to link it to meta-inflammation, but there is no exact link between meta-inflammation and chronic pain.
Okay, the next question. If a patient has a symptomatic compression fracture on an X-ray, should they have a CT scan as well?
Sure, that's questions directed to me, and also the next question. About a symptomatic compression fracture, that depends on the age of the patient, where about the fracture is, and was it a high energy or not. So if it's cervical spine fracture, they must get CT scan at minimum. If it's thoracic or lumbar, depends on the age. And if it's a high energy trauma, they still need to get a CT scan. If they have any neurological deficit, they definitely need to get a CT scan. If it's old person, history of osteoporosis, so you think about it's going to be osteoporotic fracture, they're still having pain, CT scan is not going to add much information. So that really depends on history and your examination of the patient. So there's no right or wrong answer here. About the role of vertebroplasty in vertebral fracture, is a very good role of vertebroplasty for compression fractures and that are still symptomatic, and they light up on the MRI scan and is there. They respond very well to vertebroplasty. You can refer them here in Perth is done by interventional radiologists. Also, some spine surgeons do, but they can be done at Royal Perth Hospital Radiology. Dr. Scott Davis does that. you can make a referral there, even to a spine clinic. We can refer the patients for this kind of intervention. In terms of how long after the injury, that's debatable. I essentially say I'll get MRI scan, and if there's still lights up in MRI, that's amenable for vertebroplasty. As a rule of thumb, up to 3 months, there is still very good responsive to vertebroplasty, which is essentially injecting cement into the vertebral body. It not only maintains the height, also helps with the pain as well. I think next question is about prescribing diazepam for muscle spasm. I think Reza can answer that better. I might kind of advise the diazepam just as a muscle relaxant, but I think Reza can answer this question in a more professional way. I think you're on mute, Reza.
Yes, okay. I explained in my probably last couple of slides of my presentation. I rarely have given benzodiazepine to my patients, partly because I see them as in chronic setup, so they're not in acute stage. You can argue and say that, well, in acute stage, they need a little bit of muscle relaxants and benzodiazepines can be given. My advice would be, if it is going to be diazepam, you want to prescribe the diazepam, it should have end point, because almost all benzodiazepines are addictive, and there are type of addiction that actually there is no any treatments. So there is no, you can give methadone and cure the opioid dependency, or not cure, control it. But for benzos, nothing is available. What I give for muscle spasm, in fact, I give high dose of magnesium, and I give them dantrolene at nighttime. Dantrolene is one of the oldest drugs for skeletal muscle. And again, it is not regular, it is for a short period of time. The best thing for muscle spasm, and if they are motivated, is actually function and activity. They need to just keep moving, and that's the best treatment for them.
Thanks, Reza. I actually received a question earlier that ties in with this question. With the current Medicare requirements for continuing opioid scripts, how available are you for referral purposes?
Sorry, what was the question? Am I available for what, sorry?
Referral purposes.
Look, this is something that we do get a lot. So I triage patients at Royal Perth Hospital, and also that's where I work in my public. And we see that there is a huge number of patients referred for opioid authority request. And interestingly, in private also, I've started seeing patients coming to me with authority requests despite not having a private health fund. It is the way that now with current regulations, which may change, to be honest, because I don't think we have got enough resources to give authority for entire WA patients with opioid use. They need to be seen by a pain specialist, I think every 12 months now, to give authority. And we started with seeing those referrals, increasing those referrals quite significantly.
Thank you, Reza. The next question is, why wouldn't you use immediate release formulations in management of pain?
So this is kind of a chronic pain, back pain, and back pain usually is chronic. In acute stage, yes, I do prescribe it, especially at Royal Perth Hospital when I do acute pain round. They need that immediate release formulation. But in chronic setup, the research evidence demonstrated that people with chronic pain, they will have a baseline pain level. You can maintain them in this level with various of techniques and your approach. Within this baseline, they will have this increase of pain with some reason. Not organic pathologies, not because their condition is getting worse, but they will have these fluctuations. You give them drug, you increase the dose of medications, give them immediate release to the baseline. You don't touch them, they go back to the baseline. So immediate release opioid has got an issue in vulnerable people that makes them dependent on opioids and push them towards opioid dose escalation. Hence, in chronic pain condition, I'm very cautious in terms of prescribing immediate release painkillers. Now, I'll give you an example for today. I had a patient in my private room, a 91-year-old lady who can't tolerate anything else except half a dose of oxycodone. This is, I think, is absolutely safe. In fact, in that age group, to give immediate release 1 or 2 tablets per day, because if something goes wrong, you can reverse it very quickly. If they get UTI and they become confused, you can stop and reverse them, comparing to, for example, Norspam patch, which lasts for days in the system. But if I have got this patient with a past defect, 30 years old young guy has got a chronic pain, if I give him that immediate release opioid, probably I would serve him or open up a can of worms and make him prone to be kind of having a rapid escalation of opioid doses. That's why I avoid giving immediate release opioids and benzos in chronic pain setup, especially in younger patient group.
Thanks, Reza. Another question, does baclofen help with muscle spasms as an alternative?
It is alternative. Baclofen, you can prescribe it, but again, the dose and duration should be very important. Up to like 20 milligram probably is okay, but anything more than that, it can again become very addictive. And we do see these patients coming with huge doses of baclofen, and everyone starts low, end up with high doses where dependency and tolerance becomes very difficult to manage. Hence, baclofen, yes, again, but as long as there is a limit on the duration. Because if you think about a patient, they don't have muscle spasm every day, every week, every month. It again comes and goes. And if by conservative management, they can get over that period, it's fine. But for flare-ups, for a very short period of time, few tablets, few days, I think is okay.
Thank you. I think the final question for this evening is the PBS doesn't actually specify. Oh, no, there's some more. Using a pain specialist. Can it be another GP for annual review as long as daily MEQ dose is low enough?
As far as I know, look, this is very new for us as well. As far as I know, in previous legislation, it was the fact that anything less than 90 milligram morphine equivalent dose can be given without authority requirement. But as far as I know, they require authority for any opioid which is going to be used on long term and is not for cancer. That authority, that you can prescribe it for a short period of time, but if it is going to be regular, more than 12 months, then the patient needs an authority. But I may be wrong with specific criteria because this is fairly new for us as well.
Thank you. Another question, can one give immediate release PRN and slow release regular Palexia, for example, for management of pain?
Absolutely. As I mentioned, atypical opioids, I think, is the way to go. Palexia, tramadol, and Norspam patch. And immediate release, hopefully, a tapentadol immediate release will come on PBS, so it becomes easier to prescribe. Yes, but the only thing is, what is the purpose of prescribing that immediate release opioid? For example, if a guy has got spondylolisthesis, past defect, and has got this chronic pain, but he's going to gym, he wants to do the physio and needs something to cover his pain to let him to do the physio, I'm very happy to support that and prescribe. But those people are the one that actually needs a regular follow-up, making sure that there is no dose escalation and the purpose of that immediate release has been justified. In elderly group, I said I'm more liberal because the risk of dependency and tolerance is less in those groups. The other thing with opioid, especially immediate release or long-term opioid, is the fact that they cause opioid-induced hyperalgesia. And we see them actually in pain procedures or after the surgeries. If one person is not on any opioid, they recover so well after the procedure with pain management. The person who is taking opioids for a period of time, they respond during the procedure to surgical stimulation. Their blood pressure is all over the place. After the surgery, the pain management is almost impossible, and the length of the stay and rehabilitation becomes so long. And those are the clear signals that long-term opioid use changes at molecular level in the nervous system, makes people to be very hypersensitive, let's just say low threshold for pain, basically.